parameters to do so. And then, of course, as was talked about very nicely in the opening talk, is that we can also use TMS in a repetitive way, or a way to modulate cortical excitability. So you can either upregulate or downregulate excitability. And when we conceptualize that in our lab, we're thinking about a way, again, to change for a transient period of time the excitability in a region that we would like to target with our rehabilitation interventions. So we're using it in a way to prime the system for learning. Okay. And so what I'm going to focus on, since I think there's going to be a number of talks on repetitive TMS and other more classical forms of stimulation, I'm going to take one moment to talk about how we measure and modulate plasticity directly, or at least what we think are systems level indexes or relations with classical synaptic plasticity, and that's through a technique called paired associative stimulation, where we pair peripheral stimulation of a peripheral nerve, in this case the median nerve in the right arm, and then we combine that in time to try and have synchronous arrival of the afferent input from the peripheral stimulation with the cortical stimulation from TMS, both guided to that left motor cortex. If you get the timing right, i.e. there is synchronous arrival of the afferent with delivery of TMS, you see an elevation in cortical excitability. So here's the arrows when pass occurs. At baseline, you have an MEP of a certain amplitude. After the stimulation is completed, you have a period of elevated excitability. And what we think is that this period of elevated excitability is where we may be able to intervene and be able to try and drive more experience-dependent plasticity. What's important to note is that these effects mimic what we see in the synapse, that you have these long-term potentiation or long-term depression-like effects, where you have a situation where the change in activity evolves relatively quickly. PASS only takes about 10 minutes to induce an effect. That it's reversible. Again, at 24 hours, individuals go back to their previous level of excitability, and that it persists beyond the stimulation period. So not only do we see a change in excitability during stimulation, we see it after. And that it follows temporal rules. So if you get the timing wrong, so to speak, or there's asynchronous arrival of the inputs, you actually get a depressive effect rather than a potentiated effect when you have a synchronous input. So we think we're leveraging some of the synaptic mechanisms of spike timing dependent plasticity to change the activity in these populations of synapses. So who cares is our first question, is because at the end of the day, in my lab, we're really interested in behavior and how an individual can perform movements better. And so it's great that we can change the excitability of the brain using non-invasive brain stimulation techniques like PASS, but does it actually have any effect on the ability to learn? And so Jackie Palmer in the upper corner, she's a postdoctoral fellow in my lab, and she did some really great work showing that if we do this paired associative technique, that we can increase excitability immediately after the stimulation is completed. But when we look at a very simple task, a serial reaction time task, a task of sequential motor performance and motor learning, we actually don't see an effect on performance within the session. We don't see that individuals acquire information faster or to a greater extent following PASS compared to a sham stimulation condition. But we asked the individuals to come back 1 week later to see if there was any change in learning, so this ability to retain what they had acquired. And it turns out there was. It turns out that although we don't see within session performance improvements, what we do see is a retention of skill. In fact, we see enhancement of their ability to perform the skill compared to when they had finished the training. And that was only observed in the groups that received the real PASS intervention. In this case, PASS, whether the target hand was active or at rest. That's the only difference between the black bar and the gray bar. So this was pretty compelling evidence to us to show that in young, healthy individuals, you can actually have neuromodulation prior to training result in enhanced learning. So that's chapter 1. Hope you're all doing okay. So the takeaways from this is that experience is the primary driver of neuroplasticity, that to learn skill movements requires experience, and that experience is underlined by memory formation. And we think modifying experience is actually a form of neuromodulation that doesn't involve direct, electrical stimulation of the brain, either through TMS or TDCS or TACS, but you can actually modulate the system through experience. And lastly, that non-invasive brain stimulation techniques can modulate activity and do seem to show some positive effect towards learning. So I always stop at this point to ask if there are any questions. So I'll take one moment and then we'll move on. So the second chapter is now moving into our work in rehabilitation, where we're looking at ways to perturb and image the system in individuals after they've experienced a stroke. And I will also want to make it very clear that in this talk, although I'm focused on stroke, a lot of the underlying principles apply across neurologic disorders, psychiatric disorders, that this idea of plasticity is universal. So this is a video that I wanted to play, and this is an individual here. This is our rehabilitationist, our therapist, working with one of our patients. And what I would like you to see is he's had a stroke that affects his left arm. And he has a very difficult time being able to accomplish his task, which is to lift a lid. You can see he's not able to grasp it. And he is in the chronic phase of recovery after his stroke. So all of the spontaneous recovery that occurs has already been completed. So now what he's trying to do is regain further function. And you see it's very challenging for him. So this is the problem that we're facing, is that most individuals after they've had a stroke do not regain their previous level of function. As a matter of fact, it turns out that up to 80% have persistent impairment of their arm, and that they're not able to accomplish their activities of daily living like they were able to before. And globally, we know that stroke is the leading cause of serious long-term adult disability, and that the prevalence is expected to increase quite markedly in the next 20 years, as well as the projected medical costs. So this is what we think is an urgent medical need. And the good news is that stroke mortality has actually been decreasing. So the field has gotten much better in stroke, acute stroke management. So fewer people are dying after their stroke. The challenge there is that that means there are more people living with the effects of stroke, and our ability to rehab or to perform, help them regain their level of function has not kept pace with these acute advances in management. So what the situation has resulted in, and what we're focused on, what we're trying to change, is that, or directly address this increasing number of stroke survivors that have unmet rehabilitation needs. So can we figure out better ways, better therapies for these individuals to help them regain their previous level of function? Okay. So now this is the original schematic, the model that I showed earlier, and now we've added this piece in terms of recovery of function. So we conceptualize the issue of that the loss of function, to be able to regain that ability to function, means regaining or learning new ways to move, which again will require some sort of neuroplastic change structurally and functionally in the nervous system, and in particular in the brain, and as it pertains to controlling movement. Again, experience is how we get there, and traditionally in rehabilitation, this is what we do. We ask individuals to move, and we know that asking individuals to move, and to move in a skilled way, helps them be able to move better. But it's incomplete in terms of its ability to recover function. So we know that stroke triggers these peri-infarcts, so around the area of the lesion that you have acute changes. But it's important also to note that even though stroke occurs in one hemisphere, it's not a unihemisphere result. We have distant effects as well, both in the same hemisphere where the stroke occurred, but as well as in the contralateral hemisphere. And this is due to many different factors, including changes in task-based activity, other physiologic underlying circuit changes, and what you see as a result is this reorganization of cortical activity as it pertains to movement. And this was shown very early on in seminal work by Dr. Randy Nudo's lab at the University of Kansas in the States, showing that if you induce a stroke experimentally in squirrel monkeys, that you get rapid remapping of the representations of the stroke-affected limb. And that if you don't intervene, if you only allow spontaneous recovery to occur, that you have these permanent changes in remapping that reduce the ability for the animal to perform skilled movements. However, if you ask these animals to engage in what we call monkey rehab, that they actually have mapping, they actually remap to a point where regain, or the representation of the distal extremities remains as a function of rehab. So this is some of the first work that informed our understanding that rehabilitation changes the brain, and that we are able to, that this change in the brain underlies a change in behavior. So Of course, the lesion location will influence how one recovers from a stroke. This is an example of some of the diffusion tensor imaging work where we perform tractography of the cortical spinal tract bilaterally, both in the non-stroke hemisphere and then the stroke hemisphere, which is indicated in red. And in these individuals, if we perform TMS, we actually don't see any peripherally evoked response. We see what we call an MEP negative. There's no matter how hard we stimulate, we don't get a response in this. And so this is very different than the experimental model of stroke that Dr. Nudo's group showed very elegantly in these experimentally induced strokes in the motor cortex. That's not really reality. What we see is very heterogeneous locations of stroke that can impact subcortical structures, especially these primary output pathways that are responsible for performing skilled goal-directed movements. So why do we care about that? We're very much interested in improving the prognosis of motor recovery post-stroke. So some work that my PhD student is currently engaged in is employing a predictive model to try and predict where an individual will be 3 months after their stroke. So how much will their function change as a course of their recovery? And it turns out that if you include TMS in the acute assessment of these individuals to see if that cortical spinal tract is still functionally intact, i.e. if you can elicit an MEP, that is a positive prognostic sign. That means there's a good likelihood that they have sufficient neural substrate available to benefit from rehabilitation. So if you incorporate this into a model where you test strength, you know their age, and you know a little bit more about them, you can put them into, or stratify them into different categories of how much they're expected to recover, from excellent recovery to poor recovery. So why do we care? Because we think that if we know how much an individual is expected to recover, we can design our therapies to meet their specific needs. So this is an important way for us to apply precision medicine into rehabilitation. So and this will become a common theme in the rest of my talk, is that there's not a one-size-fits-all approach for rehabilitation, nor is there a one-size-fits-all approach for neuromodulation strategies, especially non-invasive brain stimulation strategies. So Mary Alice here in the upper right corner, she's actually looking at, does this work in a hospital setting in the States? And if it does, how does that improve our ability to treat our patients? So this is one way where we're using TMS, very simply, a very simple way of applying TMS to be able to assess the functional integrity of pathways critical to the ability to produce movement. And if we have that information, we now have a better opportunity to understand how an individual will likely recover. So back to neuroplasticity. So how do we drive that in the clinic? Well, we basically harness a number of neuroplastic principles, this idea that you have to use it or you'll lose it, that the task has to be salient, it has to be important to a patient, that you have to do a task over and over. You can't just perform a movement once and expect it to be learned. So we apply many of these principles to basically design an effective therapeutic program. And so if you do that, well, you'll see this is the same patient I showed you before. And again, his stroke was on the left side. Now you can see his function has changed. He actually shows a much better ability to control his left arm that was affected by the stroke. He's able to grasp, he's able to turn his arm in and out. He can now pick up a lid. So this is all evidence that he has improved through rehabilitation, right? Which is great for us. What's not great for us is that was a very intensive process. It took weeks for him to even regain that small amount of increased function. So even though we know what's sort of optimal for harnessing experience-dependent plasticity, it's still insufficient to meet the needs of our patients, right? So what amount of practice do we need? How much use does an individual have to have? It has to be thousands of repetitions. And this has been shown in the animal literature as well as the human literature, that if you don't have sufficient dosage, sufficient amount of therapy, you're not going to have lasting structural and functional change, supporting lasting behavioral improvements. But what do we see in the real world clinic, at least in the States and in Canada? We see order of magnitude less use for these individuals. So they're not actually driving neuroplastic change in the clinic. And if we think that's important, we have a problem. Now, it's very difficult to change clinical practice. So what we've tried to do is a different strategy, is can we augment the ability to drive neuroplasticity with neuromodulation, right? And so you can do that a number of ways. We do this in the lab where we're using virtual reality techniques, robotics. I'm not going to talk about that today, given the focus of the meeting. What I want to talk about is our neuromodulation approaches, like I mentioned before, PASS in particular, and how we may be able to drive neuroplastic change to support a better ability to move and a better response to rehabilitation. So to complete the model, we now add, in this case, non-invasive brain stimulation as a way to augment endogenous plasticity. Okay? And many of you, I'm sure, are familiar with the conventional or the classical approach to do this in stroke, where one can either try to upregulate suppressed excitability in the stroke-affected hemisphere, or one could try and downregulate what's thought to be excessive activity in the non-stroke affected hemisphere. And this has been done for over a decade now, with some successes reported, but overall, when you look at the vast amount of literature, there's not a conclusive effect in the ability of conventional RTMS paradigms to improve function after stroke, right? And what is this based on? Why do we try and upregulate the stroke-affected hemisphere and downregulate the non-stroke affected hemisphere? We think it's because there's this change in the relative balance of activity between the hemispheres. That you have a downregulation of activity in the stroke-affected hemisphere, denoted by the arrows here on the right compared to the healthy condition. And then there's now a subsequent upregulation of the non-stroke affected hemisphere, and this seems to be mediated directly by transcallosal projections. So the question is that actually the case, and for who does this model actually fit? It turns out that it's really important based on the underlying structural integrity and the underlying level of impairment for individuals, whether or not this model likely applies. That will become important in the subsequent slides. So RTMS and stroke, why do we see relatively equivocal effects in using RTMS? We saw very impressive evidence of RTMS effects in psychiatric disorders to change mood, to change other aspects of cognition. But in stroke, we don't seem to see the same effects in the ability to change movement. And so this is some work that we did before. In red are just the stroke lesions, and hopefully you can appreciate they're different sizes, they're in different locations, and all these individuals have different levels of impairment. However, the field typically provides what we consider a homogeneous intervention, that we use standard stimulation parameters, that we have a common target, typically it's the motor cortex, and that we, again, sort of take this one-size-fits-all approach, even though we know that these individuals are all quite different. So we looked into this some years ago now, and tried to say, are there neurobiological markers that would predict an individual's response to stimulation in stroke? And it turns out we found that the sort of relative residual neural substrate that we were targeting with stimulation, in this case the ipsilegional primary somatosensory cortex with excitatory stimulation, turns out that the amount of volume of the white and gray matter only in the region that we were targeting with stimulation predicted how much these individuals would respond to the training paradigm. So if you don't, and what we take this to the mean is that if individuals don't have enough residual neural substrate to activate, they're not able to benefit from the effects of the stimulation. And this was only shown in the group where we pair active stimulation with the training, not for a sham stimulation. So it really seems to be related to the response to the intervention. So this is one just example of how we're trying to identify potential responders to neuromodulation in stroke. So I want to get back to these transclosely mated interhemispheric connections. We've shown through TMS EEG, which I'll talk about very briefly at the end, and I know we have some talks coming up later that'll go into more depth and detail of this, that we have abnormal connectivity between the hemispheres, and in this particular, between the two motor cortices. And that it seems to be state dependent, meaning that this abnormal connectivity seems to only arise when an individual is performing an active movement. At rest, it seems to be not different than normal controls. And importantly, this change, this sort of heightened connectivity or increased interactions between the hemispheres is strongly correlated with their level of impairment in the chronic phase of recovery. So our question is this maybe a potential biomarker that we could target with non-invasive brain stimulation in a new way? And so this, again, harnesses the conceptual model of this imbalance, this change in activity between the hemispheres after stroke, but it's thinking about it from a slightly conceptually different point of view, and we try to use a different paradigm to try and target plasticity induction within these connections directly. And that's what I'll talk about now. So the approach is called, again, paired associative stimulation, but instead of pairing a peripheral stimulus, a central stimulus, we actually paired two TMS pulses in time, and in this case, overlying the right and left motor cortex, and what you can see in the illustration here. And so in healthy individuals, one lab has done this in the past and shown that you can actually modulate the amount of activity between the hemispheres using this paradigm, and that it seems to have some transient effect on motor performance. So our question was, does this have a similar effect in modulating this abnormal connectivity in individuals post-stroke? So that's the paradigm that we use, and I'll show you some of our preliminary data. So these are relatively new and haven't been published yet, but I wanted to share them with you today. But before we get to that, the other concept about individualization, I want to return to that, is that, again, after stroke, you're going to have structural and functional changes in various pathways. Maybe you have changes in these pathways mediating activity between the cortices, maybe you do not. But we think it's important that you actually assess the functional connectivity, essentially, in these individuals and tailor the stimulation paradigm for individual profiles as it relates to the connectivity between these two hemispheres. So we have some good evidence from healthy individuals that if you don't get the timing right with this cortical pass paradigm, that you actually get the opposite plasticity induction. So if you only have a 5 or so millisecond change, whether you are, when you're timing this paradigm, you can either have an increase in plasticity, or if you change the paradigm by simply 10 milliseconds, you actually will now get a depression in acceptability. So we think that timing is probably everything in this paradigm. So we've developed an approach to try and look at the relative differences in the timing of signal conduction between these pathways using an approach that is called interhemispheric inhibition, where you pair two stimuli in a given period of time, and if you get the timing right, you will actually see a reduction in the output, the MEP, the peripheral output, compared to when you don't pair the stimuli. So what we do is find the timing, i.e. the interpulse interval, where we get the maximal inhibitory effect, given that this, we think, is the timing that is optimal for synchronizing inputs between the hemispheres. And so again, the same paradigm, we do this, and this was just one session, 100 pairs of stimuli delivered at the individualized interpulse interval, or at a standard 8 millisecond interval. So we wanted to see, is there a superior effect of the neuromodulation if we individualize based on neurobiology? And it turns out we do see that. We see that there is an elevated level of ipsilesional excitability if we individualize versus not. And excitingly, we actually see an increase in the effect on behavior if we individualize. So if we individualize the stimulation parameters, only this one parameter in this case, we actually see improvements in their ability to perform this reaction time task, then compared to if we do a standard or we do a control stimulation paradigm. So this speaks to the importance of individualization when you're thinking about delivering your neuromodulation paradigms and finding valid and theoretically sound biomarkers to base that individualization upon. Okay. So this is just a summary of some other lab that we other work in the lab that we've done, showing that we've actually are able to induce plasticity, that it seems to support memory formation as evidenced by enhanced skill learning. That's what I showed you earlier. And that data that I didn't show you, that we actually, in individuals with stroke, we can see improvements in performance. So I showed you healthy data. We also have stroke data showing that if you deliver stimulation before training, you can actually have an effect on the skill that was learned. But importantly, we also see some generalization to other tasks. So you can actually have an effect that transfers from not only the task that was trained, but also onto other tasks involving the extremity that was affected by stroke. So That's 2 chapters down. I'm not sure on timing, so hopefully we're doing okay on time. I'll go very quickly through the last point. Again, just to very briefly summarize, non-invasive brain stimulation, in this case, the only example I provided today was PASS, can be used as an assessment tool, but also as a neuromodulation tool. And I think the other very important piece that I'd like you to take away from the talk is that it's critical to individualize stimulation, to maximize the effect, and to increase the numbers of responders to the individual stimulation effects. And perhaps we can actually use TMS and other perturbation imaging approaches to identify those likely responders. Right? Because it's probably the case that not everyone will respond to non-invasive brain stimulation. So we want to know who those individuals are that will respond. So the last chapter of the talk is talking about how we're trying to develop more sort of leading edge combined neuroimaging and stimulation approaches to causally probe brain circuits. And so why do we want to do that? We think that the standalone TMS, and looking at that as a measure of cortical excitability, is fundamentally limited in its ability to characterize cortical activity. We are typically limited to brain regions that will elicit a peripheral response, like the motor cortex or the visual cortex, right? And we have limited ability to characterize the connectivity between regions of the brain and look at causal relationships from when we stimulate one area of the brain versus the activity elicited in another area. So what we focus on in the lab is combining TMS with electroencephalography, or EEG, in real time to have a causal paradigm to essentially evaluate the effects of activating one area on the activity in another area. So in the bottom right corner is a very standard 32-channel EEG topology where we've flagged it out, and you can see TMS is delivered over the right motor cortex. You get local activity, as one would expect, but also you can appreciate, even on the other hemisphere, we get responses that are elicited that are different, both in their spatial and temporal characteristics, and that's what I'll show you some more examples of moving forward. But what we like here is that we're using a causal approach, this TMS, to perturb the system, and then using a imaging modality that has very high temporal resolution, so we can actually measure responses in real time that are biologically relevant. Okay? Again, the key here, we won't spend much time on this, is that EEG also provides us a direct index of neural activity. So it's telling us about the postsynaptic potentials that are occurring in a synchronous fashion in the regions where the electrodes are overlying. And the key to remember is that the temporal resolution is on the millisecond timescale, meaning that we can actually see activity induced by TMS in real time. Again, we're using neuronavigation to target the brain areas of interest. Again, for the purposes of today, we're just talking about the motor cortex and looking at measuring the responses. So what do we see when we do that? We get this rich spatial temporal dynamic response to stimulating the cortex, and that it varies. So if I stimulate the left motor cortex versus if I stimulate the right motor cortex, we get a different pattern of activity that's elicited. This is just to show you that we're actually seeing something unique when we stimulate unique areas of the brain. And that over this time from stimulation to roughly 200 milliseconds, we get very interesting information about what's occurring, both in this case local to the region of stimulation in the left motor cortex, but also in other regions as it evolves over time. So we've done this a bit now in stroke to see if we can get better measures of cortical excitability directly using this paradigm. This might be very important in those individuals that we talked about before where we're not able to elicit an MEP. So we have limited understanding of the cortical reorganization in this population of typically severely affected stroke survivors. And that might be very important for us trying to deliver or to develop and deliver effective rehab interventions, whether they're robotics, brain-computer interface, to have an appreciation of the network dynamics in these folks. And what we see if we do this in individuals after stroke, we actually find novel changes in cortical reactivity with TMS-EEG that seem to be correlated with their ability to move their paretic hand. So this was our first sort of demonstration that we have abnormal TMS-evoked EEG responses post-stroke that seem to have some correlate with behavior. And of course, I showed you earlier just a very simple example where if we stimulate the motor cortex, we can actually elicit changes in connectivity between the hemispheres. and that this seems to be state dependent, that it's an activity dependent process. So what it does is it opens up a window for us now to ask very new questions about changes in cortical reorganization post-stroke. And that's really where our lab is going in the future, is trying to develop sophisticated approaches to not only deliver and measure the stimulation, but how we might be able to analyze it. And that's what is in the bottom right corner. This is just an image, a video of analyzed data looking at the TMS evoked response and taking a graph theoretical approach to try and model the activity as it propagates through the cortical brain network. The other thing I wanted to highlight is that we're not only doing this in the upper extremity, we're also trying to understand how the brain might organize differently as it supports lower extremity movement like walking. Is there a different neural substrate that underlies that process? And actually our preliminary data suggests that it is, but I won't go into all those details today. So I just wanted to end on, in this case for the chapter 3, is what I envision the clinical promise of TMS EEG is, and I think for those of you, especially those of you who are younger in the audience, may have the opportunity to really develop and contribute to mature this field, because it's a very young field in terms of combining this perturbation imaging in real time to actually measure important aspects of brain activity. So again, the advantage is that we can assess multiple cortical properties on biologically relevant timescales. So it allows us, again, to ask new questions that we couldn't ask before when we just use imaging alone, or when we just use stimulation alone. That we can now also look at, get outside of the motor system when we're using TMS to probe other circuits that may be quite important, both in stroke, but also in other neurologic disorders or neuropsychiatric disorders. So it improves our ability to make causal inferences about the contribution or the functional contributions of different brain areas to different behavioral phenomena. Of course, we can investigate different brain states, so we can look at what are the what is the makeup or what's the composition of neural activity that underlies a specific brain state, whether it's an altered state of consciousness, whether it's sleep, whether it's actually during a task and that individual has varying levels of arousal or awareness or attention. We may be able to actually use that information in real time to determine how best to deliver our intervention. And one example that's been shown in the literature and something that we're actively doing is trying to use online recordings with EEG of brain activity to determine when we should actually deliver stimulation. So it seems that specific brain states that vary in time, of course, the brain is a highly dynamical and nonlinear system. If we can understand those changes in time and tailor now our stimulation moment-to-moment brain states, we're more likely, at least from the early data, to have a larger effect of the stimulation. So it's another way, again, of thinking about personalization and individualization of brain stimulation to optimize the neuromodulatory effects. So overall, I hope that I've convinced you that characterizing and positively augmenting neuroplasticity has potential for improving movement ability, both in health and in disease. That non-invasive perturbation and imaging tools, they really offer a window into neuroplasticity in humans. And if we think that neuroplasticity underlies our ability to learn, these tools are critical for increasing our understanding of how humans are able to learn and relearn in the context of disease and injury. And again, we know that neuromodulation can augment now, positively or negatively, actually, but mostly positively augment experience-dependent plasticity, however it has to be individualized. And lastly, that multimodal real-time integration of neuroimaging and perturbation tools like TMS provides us new tools to causally probe the activity of brain circuits, underlying movement, and other behaviors that one might be interested in. So I'd like to return to this slide to acknowledge again my collaborators as well as the members of the lab who are engaged in this work, and also to our research participants and all the funding agencies. And with that, I'll conclude and just give you one example of where I'm coming from. So I'm very much enjoying my time in Shenzhen, and I just wanted to show you what Atlanta looks like. In the background, that's the Atlanta skyline, and then in the foreground, that is Emory. So I'd like to just invite you all, if you're in the States and in Atlanta, to come to Emory, and I'd be very happy to show you around and return the hospitality that I've received thus far. So thank you very much, and I'll take any questions.
非常感谢迈克的精彩演讲。